Yeah, well, looks like we have a number of quite a good turnout, so I think we should get started. So we're very happy to have Dr. Emily Moore here with us today and talking about pain and managing persistent pain, looks like. So please take it away.
Will do. Thank you all for being here. I'm really excited to be here today to discuss this topic. You might be wondering why I have this somewhat odd image on the title slide. So, today's talk is focused on how to harness the power of the brain to manage pain experience. The image highlights how everything we experience is filtered by our brain and the fact that a number of factors, our past experiences, expectations, and attention, influence how our brain computes experiences. Some of you may see a young woman looking off into the distance, while others will see an older woman smoking a cigarette. Many of you will be able to switch between by shifting your attention to different aspects of the image. Vision is constructed. Our brain determines what we experience, but we can alter our experience through understanding the brain. Novel approaches in pain psychology have harnessed this fact to make significant strides in treating chronic pain. A little bit about me before we jump in further. So, pain has been a theme in my training and now early career. I completed my PhD at McGill University in Canada, where I was involved in research on pain catastrophizing, which is sort of an unhelpful mindset that's been identified in thinking about and relating to pain. And I focused on its relation to functional outcomes, so quality of life, return to work, things like that. I subsequently undertook my residency at the Allen Edwards Pain Management Center in Montreal as well, working with a wonderful multidisciplinary team before I relocated to California to complete my postdoctoral fellowship in pain medicine here at Stanford. I'm now back at Stanford as faculty and have had the privilege of working with a few people diagnosed with Parkinson's disease in the context of optimizing their pain experience and quality of life. I have no disclosures to make today. All right, let's get back to the brain. I want to once again highlight the power of the brain through this brief clip. As you watch the spinning mask, take note of what you see. For most people, the face pops out towards us despite the mask turning and the sunken back being exposed. This is because our brain expects noses to stick out and therefore alters the image. Again, we see with our brain, not with our eyes. Similarly, we experience pain largely with our brain. The Tale of Two Nails is one of my favorites and captures this really perfectly. So, back in 1995, the British Medical Journal reported on a 29-year-old construction worker who'd suffered an accident. After jumping onto a plank, a 7-inch nail pierced his boot clear through to the other side. In terrible pain, he was carted off to the ER and sedated with opioids. However, when the doctors removed his boot, they discovered a miracle. The nail had passed between his toes without penetrating his skin at all. There was zero damage to his foot. No blood, no puncture wound, not even a scratch. But make no mistake, despite the absence of injury, his pain was real. So what happened? Sensory receptors in the man's body reported to his brain that there'd been an accident, that a nail had penetrated his boot. His brain, perceiving potential threat to his safety and well-being, used context to determine what had occurred. Collecting information from his 5 senses, including the visual of a nail sticking out of his shoe, knowledge of the dangerous work environment and its risks, his coworkers' horrified faces, and other data to make a guesstimate about what had happened and how to respond. Thoughts, beliefs, and emotions, including panic and fear, set off a cascade of biological and neurochemical processes. His brain, synthesizing the sum total of this information, decided that he was in danger, so it made pain to protect him. In this case, real pain was generated entirely as a result of factors having nothing to do with actual tissue damage, yet was as intense as if he'd actually been stabbed by that nail through his foot. On the flip side, we have the scan of this man's head. Another construction worker, seriously dangerous job, was using a nail gun when it unexpectedly discharged, clocking him in the face. However, other than a mild toothache and a bruise under his jaw, he thought he'd escaped relatively unscathed. 6 days later, 6 days of eating, sleeping, and going to work, he went to the dentist. And much to his surprise, an x ray revealed a 4-inch nail embedded in his head. Indeed, the nail had pierced his cerebral cortex, putting him in potentially grave danger. However, because contextual cues failed to put his brain on high alert, his pain system remained quiet, despite actual bodily harm and need for medical intervention. This shows us that pain is complicated and influenced by a multitude of factors beyond tissue damage alone. Here we have the official definition of pain from the International Association for the Study of Pain. And I like to highlight this here so we're all on the same page about what we're talking about when we're talking about pain. So, pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The key parts here are its sensory and emotional experience, highlighting the importance of our perception and our emotional state. And then also this flexibility here with resembling that associated with actual or potential tissue damage, really capturing, like we saw, what happened in the tale of two nails. What this means is that pain is a dynamic process. All pain is activated by the brain. No brain means no pain. There are two major causes of pain, some kind of tissue damage, or what we call learned neural pathways. Learned neural pathways refer to patterns of activity in the brain that develop through repetition and become hardwired over time. They're the result of neuroplasticity, which is the brain's ability to adapt and rewire itself based on experience. So, for example, if I was to go to Pilates tomorrow and fall off the reformer and break my ankle, that initial pain would be very much related to tissue damage. However, if in 6 months or a year I'm still experiencing pain in my ankle, despite having it surgically corrected, despite the x rays showing that it's healed correctly, I might start to wonder if the pain that I'm experiencing could be related to the brain circuits that developed in the acute phase of my pain when my ankle was actually broken. And now that my ankle's healed, for some reason my brain is continuing to send those signals and has almost forgotten to turn it off. I think of it as like turning on a light switch and the brain just not quite getting there to actually turn it off. Again, though, that both types of pain are experienced identically. There is no imaginary pain. This is not to say it's all in your head in this, sort of stigmatized, dismissive way that pain was previously described. We now know that regardless of the source of pain, they are indistinguishable, whether it's related to tissue damage or if it's largely being driven by learned pathways in the brain. In individuals with acute pain, tissue damage problems, things like infections, fractures, kidney stones, are very common. But in chronic pain, pain that's persisted for more than 3 to 6 months, we're finding that it's actually much more likely to be due to learned neural pathways. With a number of situations being exceptions. And of course, we always want to have medical workup for new onset pain. But if physical tissue damage has been ruled out and you're getting a lot of reassurance from physicians that there's nothing physically wrong, it can be helpful to then turn about to thinking about the way the brain might be relating to the pain and whether there's other ways to address the pain that you're experiencing. Non-structural pain is often called neuroplastic or nociplastic pain. Nociplastic is the official medical term. Neuroplastic has become more popularized in recent years, and it's kind of a play on words with the idea of neuroplasticity, the brain's ability to change over time. In other words, what we mean by neuroplastic or nociplastic pain is that it's pain primarily caused by changes in these neural pathways rather than physical damage to tissue within the body. We understand neuroplastic pain as occurring because despite nerve fibers and tissue in the body sending safe messages, the brain somehow is misinterpreting these as instead dangerous. Neuroplastic pain is thought to be made up of sensation plus fear. It's the sensation coupled with fear that seems to prompt the brain to interpret danger and signal pain. Again, very important here to note that all pain is real pain. Whether you have a structural injury or your brain is misinterpreting signals from your body, the pain is being processed in the exact same way. All pain is generated by the brain. We can't experience pain without the brain as that processing of the sensation and input coming in from the body. I'm by no means an expert on PD, but here are a few pain-specific facts that I came across in my research for this talk. So, chronic pain is twice as common among people diagnosed with PD compared to the population. 80% of people with PD endorse pain. I found that really shockingly high, and gives extra relevance to us having this conversation today. It also was noted that it is often the most interfering non-motor symptom that patients report. Um, there were many types and sources of pain described in the literature. MSK pain, so pain related to muscles, bones, or the skeleton. Dystonic pain related to painful muscle spasm. Neuropathic pain, so changes in nerves, so that sharp shooting type pain. And then central pain. And central pain refers to changes in the way the brain is receiving information in the body, very much overlapping with this idea of neuroplastic pain. So we see a mix, it seems, of structural pain and nociplastic pain in patients diagnosed with Parkinson's disease. The good news, though, is that the strategies we're going to discuss today can actually be beneficial for all types of pain because they harness the power of the brain in modulating our experience. So pain psychology from a neuroplastic pain standpoint has really tried to use the strategies we'll be talking about today to eliminate pain, but we've also found that when there is a structural issue going on, that we can still use these strategies to calm down the central nervous system, which we'll talk about more, and help the brain interpret them at a lower intensity. So we're not going to make structural pain go away by using our brain, but we can definitely reduce its intensity and its interference. Um,
What do you mean by endorse pain? What is the sense of that? Just that they have it? Is that what that means?
yes,
Yeah.
yes.
Okay.
80% of people diagnosed with Parkinson's disease say that they are experiencing persistent pain.
Got it. Thanks.
Of course. I want to cover a little bit of pain neuroscience education so that we have a foundation for understanding the rationale behind the tools we'll be talking about. It's important to recognize that pain evolved as and continues to be a danger signal. It's our brain's way of protecting us from causing harm to our bodies. If you put your hand on a hot stove, the pain lets you know to move your hand so that you don't injure yourself further. But the pain system is not perfect. Sometimes these danger signals can get activated even in the absence of structural damage, or they're too loud when structural damage is quite minor. Building on what I said earlier, false alarms are just as loud and feel identical to real ones, which is why a smoke detector is a great analogy. The way we respond to pain either reinforces a sense of danger or creates a sense of safety. And this in turn contributes to subsequent pain processing. If we hold the belief and feel as if there's something wrong in our body, understandably, we will feel in danger. To emphasize this idea of our response being key, think of a toddler that falls down. Their response to that event is actually highly predictable based on the reactions of the caregivers present. So, if the child's mother gasps as the child's knee hits the ground, they sense danger and they cry. But if instead the mother says, whoopsie, and smiles, the child gets up and continues playing. In chronic pain, when we respond to pain with fear, it reinforces that it's dangerous and contributes to the pain persisting. Remember that earlier definition that I shared that pain equals sensation plus fear. If we can cross out or reduce fear, we eliminate one of pain's fuel sources and we're simply left with sensation. On the other hand, when we have a lot of preoccupation around pain, it reinforces to the brain that the pain is dangerous, and this contributes to the pain persisting. Each of us has an autonomic system that is constantly assessing whether we are in danger. The autonomic nervous system is part of the central nervous system, so the brain and the spinal cord, and it plays a crucial role in pain because it regulates the body's stress response, and this directly influences how pain is perceived and whether it's maintained. So the autonomic nervous system has two branches. The sympathetic branch, or what you may have heard, the fight or flight system is what it's commonly known as. This activates during stress or danger. And then we have its counterpart, the counterbalance, which is the parasympathetic nervous system, or what is often called the rest and digest system. This promotes relaxation and recovery. I like to consider these danger mode, the sympathetic state, and safety mode, the parasympathetic state. Many people navigating medical challenges, including a Parkinson's diagnosis as well as chronic pain, are stuck in danger mode. This is problematic because it causes physiological changes like increased muscle tension and makes our brain very much on high alert, which means that it's more sensitive to input from the body, which can cause pain amplification. It can be helpful to think of the autonomic nervous system as a switch between danger mode and safety mode. In chronic pain, the system often gets stuck in danger mode and amplifies the pain. By engaging in the parasympathetic mode or safety mode, we can help the brain and body reduce pain and return to balance. We're going to talk about how to do that in a minute. I also want us to take a moment here, though, to speak beyond pain, because even if you're sitting here listening and you're like, well, I'm not experiencing a lot of pain, understanding and balancing your central nervous system or regulating your central nervous system is still highly advantageous, because the reality is that our brain and nervous system evolved for back when we were cavemen and cavewomen, and society has evolved much more quickly than our physiology can. So there's a bit of a mismatch between how we function and the world we live in. So many people, even, typical healthy people, are also quite often stuck in a sympathetic response because we're constantly being bombarded with emails and text messages and traffic and information and scary news that's constantly pulling us into that danger mode. So thinking about how to optimize your nervous system, whether pain is part of your experience or not, is really a good idea and has been shown to optimize mood, decrease anxiety, and also contribute to improved quality of life. All right. So, beyond pain and medical illness, the following things can also contribute to overactivation of danger mode or the sympathetic response. Tendency towards anxiety. So, if you have state level of anxiety, if you're a person who leans towards being a worrier or generally feeling on edge, that does tend to reinforce activation of danger mode and cause that vigilance in the nervous system. So, again, whether pain is part of your experience or not, that's definitely something that we can consider tackling to try and optimize well being. Chronic stress related to situational or interpersonal or medical stressors can also contribute. Perfectionism and self criticism cause this constant internal pressure that keeps our nervous system very much on edge. Also, a good thing to optimize. And then we sometimes see when people are experiencing very negative emotions but feel the need to suppress them. This can start to create a hostile relationship internally where emotions are perceived as threatening and they're kind of hard to escape. So, that constant suppression can also contribute to this dysregulation in the nervous system. So, this is touching just on beyond pain, other things that might cue you or put you at risk of having nervous system dysregulation, and kind of build that rationale for why you may want to incorporate some of these strategies we'll be touching on now. So, active relaxation is an evidence based option for activating safety mode to promote balance. We can kind of think of danger mode and safety mode as equivalent to muscles. right? Our muscles grow when they're used. Our life, the stress we encounter, medical diagnoses give that workout to danger mode, but relaxation mode, safety mode is not often getting exercised intentionally. So active relaxation is kind of considered a workout for safety mode. It helps strengthen that side of your nervous system so that it can fight back against danger mode and create more of that balance internally. There are lots of different active relaxation strategies. The ones I have on the slide are the ones that I perceive as having the most scientific evidence for their efficacy. Diaphragmatic breathing is something you may have heard of before, which can also be called belly breathing. This is a way of breathing where we shift the way we're breathing into the lower part of our lungs using our diaphragm, which is a muscle that's like an inverted U shape that sits just below our ribs. When we inhale, we want the diaphragm to drop, and therefore our belly expands because all our organs below it are kind of pushed outwards. And then as we inhale, our belly returns closer to our spine. In diaphragmatic breathing, we want to be thinking about ideally inhaling through the nose and exhaling through the mouth with an extended exhale. Some people like to purse their lips, almost like you're blowing out a candle, because this signals to your brain that you're safe, that it doesn't need to stay in danger mode. I like to say, our brain knows we're not running from a lion, a tiger, or bear if we're doing these slow inhales and long exhales. So diaphragmatic breathing is probably the strategy that's been around the longest when it comes to activating safety mode, and a really good one to try. Very Googleable. There's lots of information on it beyond kind of that little tidbit I gave there. The physiological sigh is kind of a newer strategy that was developed by Dr. Andrew Huberman, who's a Stanford neuroscientist. He has a pretty famous podcast now, so I assume lots of people have heard of him. A physiological sigh is a different breathing strategy that's been shown to really activate safety mode. Basically, what you do is you take an inhale through your nose, and without exhaling, you take a second little inhale through your nose before you do a long exhale. So it kind of looks like this. And so doing a couple of these has been shown to also help activate safety mode and shift us out of danger mode. With the diaphragmatic breathing, the data looks like 5-ish minutes is kind of what we're aiming for a day, but I always recommend that people start slowly, start with a couple times a week, start with less minutes, and build up from there. We want it to feel easy initially so that you build that reinforcement and actually are able to engage and make it a habit in your day-to-day life. Meditation, stretching, and yoga, I won't explain in detail as they're quite familiar, but they're also good options for activating safety mode. I have a lady on the slide doing chair yoga, which is a really great accessible option when it comes to yoga. All of them have in common this slow movement, body focused, sort of just allowing the brain to shift out of the constant stress and hecticness of day-to-day life. Leaning into positive sensations is another useful strategy for cultivating safety in your body and mind. It's also been shown to reduce pain-focused fear and turn down the volume on pain. That's my dog, Rousseau, there. That photo was taken in Canada during the fall. And I think dogs are great representations of leaning into positive sensations and just savoring the moment. He's walking around the same path, but acting like it's brand new. And for us, we can think about, for me on this walk, thinking about the leaves crunching under my feet, the sun on my skin. Focusing on pleasant sensations really allows our brain to shift into safety. And if pain is part of your experience, it can definitely help to distract away from that or soothe the mind and body to reduce the intensity of pain. Positive sensations, we can tune into things around us and how they're impacting us. And we can also create sensation for ourselves. For example, sometimes we'll talk to patients about, rubbing their thigh or stroking their hand when they're waiting for an appointment in an uncomfortable chair somewhere or something like that, just to give your brain that input of something more appealing than the pain itself. Safety statements are a cognitive strategy that are a pretty kind of bread and butter part of cognitive behavioral therapy, which was initially developed for depression. In this work, they're called often coping statements, and within the pain world, they've kind of been rebranded to safety statements. But the idea here is that we're thinking about how we're thinking about our experience and trying to shift it towards being more reassuring. We also, though, don't want this to be like toxic positivity, like completely out of touch with reality. We want it to be based on the evidence at hand, but we want to be really aware if we're thinking in extreme ways, all or nothing ways, or these more catastrophic type ways. For pain, this helps reframe the pain experience and supports a shift in the brain's interpretation, shifting ideally from a danger signal to a neutral signal in its original form of coping statements. If you're wanting to use a similar idea for more anxiety or fear, we want to think about how we can challenge the thought or adjust the thought to make it more helpful and reassuring for us. So, an example in pain would be I can't take this pain anymore. It's ruining my life. It's a pretty valid thought, and it's true for a lot of the people I work with. It's also really unhelpful. It makes them feel more scared, makes them feel very powerless. So, a safety statement in that context, a shifted thought, a more reassuring thought would be, living with this pain is hard, and I'm doing the best I can. It might also look like today pain is really high, and I know there's hope that by tomorrow it will decrease somewhat. That's been my experience in the past. Anything that, again, doesn't feel toxically positive or completely out to lunch, but that feels like it's sort of shifting you more towards the objective reality based on the evidence and that feels somewhat reassuring. Somatic tracking is a pain specific strategy that was developed by a group who's been specifically working on neuroplastic pain. And I wanted to just touch on it briefly today. I'm happy to send the organizers an example of a guided somatic tracking if anyone would like to try it. But you can also use these aspects in doing this for yourself and sort of thinking about embodying this as you move through your day to day if you're experiencing pain. So, a little bit about somatic tracking. It was initially developed to help them make the brain feel and believe that it's safe. It's a technique used to retrain the brain to interpret signals from the body more accurately and turn off or reduce pain. Really, what it's doing is it's providing experiential evidence that there's nothing physically dangerous or wrong happening in the body. Can be understood as a form of exposure therapy. So it incorporates the basic principles of exposure therapy, which are that we need to be exposed to the fear inducing stimulus in order to overcome it. So let's say I have a phobia of dogs. I'll never get over my phobia of dogs until I interact with dogs. We can do that in a gradual way that's not traumatizing to me, but I will never really be over the fear until I have more positive experiences with dogs to overcome that past learning. Somatic tracking, though, also aims to show the brain that it is safe despite pain being present. Because pain that's persistent, again, if major issues have been ruled out, is very different than acute pain, right? If my hand is on the hot stove, there is an external source causing danger to my body. I need to remove my hand. But if I'm experiencing that residual pain from my ankle break a year ago, there's nothing to escape, right? And so trying to escape the perceived danger that my brain is acknowledging is actually really unhelpful. So, through somatic tracking, we expose ourselves gently and slowly and compassionately to the pain experience, trying to mitigate fear to shift the way our brain is processing the information it's receiving. There's three components of somatic tracking: mindfulness, safety reappraisal, and positive affect induction. And I'm going to go into each of them in depth so that you have a good understanding of what they encompass. So, as you're probably all aware, mindfulness is a technique where we learn to pay attention to a sensation with objective curiosity, letting go of fear, judgment, or any specific desired outcome. Neuroscientists have shown that mindfulness can increase feelings of safety by deactivating the brain's fear circuits. That's why it was listed with meditation as an option for activating safety mode. This engagement in mindfulness contributes to breaking the fear pain cycle, the fact that fear fuels pain, and supports reinterpretation of physical sensations. During somatic tracking, our main aim with this mindfulness component is to pay attention to the pain really objectively, noticing the characteristics of the sensation, but not getting caught up in them. So I might say to a patient, or you might say to yourself, how would I describe this sensation? Is it localized or widespread? Is it tight? Just watch it, just notice it. We don't have to do anything. We don't have to change anything. We're just along for the ride, seeing if we can tune into it a little differently than we typically would. Then we want to notice what's happening as you watch this sensation from this new perspective, trying to let go of that fear. The second component is safety reappraisal. And somatic tracking is made up of more than just mindfulness alone because it's challenging to authentically be mindful when paying attention to something that feels inherently dangerous, as pain does because it evolved as a danger signal. When we believe a painful stimulus is dangerous, it becomes nearly impossible to objectively watch that sensation with ease, curiosity, and interest. So, this is where the second component of somatic tracking comes in. This component is made up of all the different things you can say to yourself to help reappraise the sensation that you're experiencing as safe. So, I might say something like, "This is temporary. We know that this sensation is safe. It's not a reflection of danger. Isn't it amazing that your brain can generate these sensations? The brain is so powerful, etc." We've ruled out, concerning medical explanations for the pain, those sorts of things that really try to reduce fear, paired with the mindfulness. The last component of somatic tracking is positive affect induction. People tend to attend to their pain with a sense of intensity because pain is scary. So positive affect induction aims to bring a positive emotional state into the connection with pain. So we're really trying to shift to seeing the pain through a lens of safety, and we can do this trying to bring in some lightness and positive affect as we engage. Excuse me. Um, so some therapists, the therapist who designed this, for example, he'll use a lot of like humor and kind of awkwardness to lighten the mood. Other people will use storytelling or analogies. I like to use examples like imagining you're snorkeling and the sensations are the fish swimming below you. All you need to do is watch them, notice them. You're not changing them, you're not chasing them, you're just allowing them to be part of your experience here. Really, this component, and if you're applying it yourself, you're really aiming to help lighten the mood, reduce that intensity. A few other options for activating safety mode and reducing danger mode that, again, here these ones work beyond pain, so just generally. So a delight practice is a strategy I learned about recently that's kind of a counterpart to a gratitude journal or gratitude practice. I think gratitude practice sometimes, especially when you're going through extremely difficult things, can kind of feel forceful and a little burdensome of like, despite everything I'm experiencing, I need to find gratitude. And there can be pressure and expectation associated to that. I like this idea of a delight practice because it's more about just noticing things around you to delight in. Like we might delight in, the sun shining through the trees or the bird chirping. And that can feel sometimes lighter and easier to people than gratitude. However, a gratitude journal is again a great evidence-based strategy for reducing danger mode and improving well-being. Slowing down, I think, especially here in the Bay Area, everyone's rushing around, and that rushing, that urgency that we move about the world with can definitely contribute to our brain perceiving us as unsafe. So intentionally slowing down wherever and when you can be really helpful as well. Self-compassion. There's lots of people writing and talking about this. At its core, it really means kind of offering yourself understanding and acceptance for your imperfection as a human, because we're all imperfect and we're all struggling in different ways, and allowing yourself to recognize that, to notice your common humanity, and to lower the stakes. If you notice yourself being really self-critical, to try and shift into a more self-compassionate voice. A good quick tip on doing that is to start talking to yourself how you would talk to your best friend or a loved one. We often speak to ourselves much more harshly than we would speak to other people we care about. And so we can borrow the voice we use or the language we use with them and turn it inwards. Savoring is pretty similar to a delight practice, but I have it separated here just to reinforce its value as well. It's an idea from positive psychology where basically instead of trying to add in good things throughout our day, we want to appreciate the things more with more intentionality that are already a part of our day. So this would look like savoring and really kind of basking in the deliciousness of the first sip of coffee in the morning, or really appreciating that first bite of food, um, savoring the greeting from a dog, or appreciating sort of the phone call from a friend, and really savoring how it makes you feel emotionally, the joy that it might bring you. If you are experiencing pain and you're interested in multidisciplinary pain care, you can always request a referral from your PCP to the Stanford Pain Management Center. At the center, we have pain physicians practicing pain medicine. There are medication options as well as lots of different interventional options if you're experiencing structural pain, nerve pain, etc., that can be optimized. And there's a great team of physicians there who I work with. We also have pain physical therapy, which is a little bit different than kind of the average PT in that they're really used to working with chronic pain, and they do a lot of pain neuroscience education and helping patients differentiate between pain that is a signal of danger and that needs to be treated one way versus more chronic persistent pain that would actually benefit from movement and PT, but that will have to sort of be tolerated in a certain way in order to then overcome it or significantly reduce it. And then pain psychology. Myself and a number of other psychologists on the team are practicing many different pain psychology approaches. Given that I wanted this to be short and sweet and try and focus on practical tools, we didn't get into a lot of the theoretical underpinnings of these approaches. I have some books that I'll show in a moment if you're interested in learning more, but our website also talks about the different options within psychology, but also the other branches of our multidisciplinary pain care. Um, if you're interested in learning more, here are a couple books that are really focused on more the neuroplastic, nociplastic pain. If you want to try and harness the power of your brain to address symptoms that might be persisting despite there not being a clear structural issue. And again, I think the way out in particular can be really helpful even if you are diagnosed with some sort of structural issue or believe you have a structural issue, because it still works on shifting how you think about and relate to the pain. And then again, I'm happy to also send over, there's a book called The Pain Survival Guide, which I forgot to add to this slide, that's more focused on how you can learn to cope with pain and implement different strategies to try and limit its negative impact on your life. And I think that's a really great book as well that came out of Australia. All right. Thank you so much for listening. I'm happy to take questions.
That's great. Thank you very much.
Of course.
So, like, I guess I'm just trying to think, if I have pain that's partly neuroplastic and partly structural,
Yeah.
like I have arthritis in my knee, and
Mhm.
it's been going on a long time, but it's kind of getting worse and worse.
Yep.
So how would I use these strategies, I guess, and
Yeah.
what might I expect?
So I think a lot of pain is multifactorial, partially neuroplastic and partially structural. I think that's the likely for most people, right? So we
Mhm.
want to think about again addressing the structural issues to the extent we'd like to or is possible, right? So with something like arthritis, there are medications and interventions that could be utilized to try and reduce the pain intensity. With whatever pain is residual after you've maximized your medical interventions,
Mhm.
that's when we want to think more about how you can harness the power of the brain to change how you're relating to or how you're processing the signals from the body. So in a case like yours, we might want maybe somatic tracking doesn't necessarily feel like it's something you need to incorporate, but thinking about regulating your central nervous system so that you're not you're not allowing your central nervous system to amplify the signals from the arthritis in your body would be
Mm.
really advantageous because we
Mm.
know when our nervous system is stuck in danger mode, it's turning up the volume on the signals it's receiving. And that's true whether you have structural pain, neuroplastic pain, whether you're someone who doesn't have pain. There was actually studies done at my lab at McGill that have shown that if we sleep deprive someone, for example, we can put them through a pain test. These are healthy volunteers. We put them through a pain test one day. Typically in research, we use a cold pressor test. So you have to put your hand in really cold water and hold it there for a certain amount of time. If we test them after a good night's sleep, and then we test them after sleep restriction, we don't allow them to get a good night's sleep. On average, they report like a 30 to 50% pain increase from the exact same test, right?
Mm.
So we know that these different factors play a role. Another example is if we scare people before we make them do the test, they also report much higher levels of pain. So we know the brain, even in structural tests, cold is causing structural damage to the tissue, that the way they're thinking about the pain, the state of their brain before they go through the test is playing a big role in what pain they then report. And so you want to think about that in trying to optimize things for yourself, whether it is regulating your nervous system, focusing more on connecting to joy, savoring to improve mood, or whether it's something like noticing kind of the cognitive traps, the thinking traps that you fall into that might actually be exacerbating your pain rather than helping you cope with it.
Okay. Thank you.
Mark?
Hey, Dr. Moore, thank you very much for coming. And um, talked about in the group, and it sounded like there was a lot of interest a few months ago when I brought it up in group, because a number of us have chronic pain. And I've gone to the Stanford Pain Center for a couple of years, and I've gone through several procedures on my back and neck where they've cauterized nerves, which has helped a lot. And then one of the doctors referred me to Dr. Moore, and I've been doing pain psychology stuff with her for a while. And things like somatic tracking and some of the other techniques that she mentioned, I don't understand how they work, but they work. Like the somatic tracking, the very first time we did it, Dr. Moore walked me through an exercise, and literally the very first time I used it, it like my pain just melted away. And again, I still don't understand it, but it works.
Wow.
And like so now, whether it's headaches or if I have like excruciating pain with my back, um, I can go through, use a number of different techniques to lessen the pain and sometimes eliminate it altogether. So I highly recommend looking more into this. It really, really works. And the combination, there's like Dr. Moore pointed out, there's several different options, not just pain psychology, but also like medical procedures and physical therapy. I haven't done the physical therapy yet. I assume it's really effective, but the other two things, especially the pain psychology, has been a game changer for me. I highly, highly recommend it. Again, thank you very much, Dr. Moore. Really appreciate you and
Of
this
course,
information
thank
that you're
you.
sharing.
Such a pleasure seeing you. Courtney?
Thank you so much. I just want to echo that. I really appreciate you coming and speaking to us. Mine's a simple question.
Yep.
What was the podcast that you were referring to?
Yeah, Dr. Andrew Huberman. I think it's just called the Huberman Podcast.
Okay, yes, I
Yeah,
feel
so
like
he speaks
Huberman,
on
is it
lots of
Huberman
cool.
Labs? Huberman, I think it's Huberman Labs.
Oh yeah, it might be Huberman Lab. Yeah, he talks on lots of different health related